everybody for having us here today, and we're really excited. Happy New Year, it's 2020, so we're saying it's the year of the eye, the year of the optometrist, so we're excited to be here. So, like she said, we're going to be talking about glaucoma today, and I'm Dr. Letlebo, this is Dr. Hunt. Like she said, we're over at Verona Vision Care. So, today we're going to be talking about what is glaucoma, and then we're going to talk about just some basic parts of the eye, some risk factors for glaucoma, maybe some symptoms you might experience, what we do at an eye exam, and then kind of how we treat and manage glaucoma. And another fun fact, January is Glaucoma Awareness Month, so very fitting that we're giving this talk today. So here's just a really simple picture of an eyeball, and I am going to walk over here. So it's kind of from the side if you were to take a cross section of my eye. So we have our eyelids and some of our lashes here. Then we have this kind of creamy colored curved part right here. That's the cornea. So that's just where people put like contact lenses on, okay? And that's just the front of the eye. And then as we move through the eye, we have just a space up here where some fluid flows. This kind of white oval is the lens. This kind of reddish part here is a jelly. And then here, this yellow line here is the optic nerve. So glaucoma is a group of diseases that affect the optic nerve, which is back here. But it's really important that we look at the whole picture of the eyeball and the person in front of us when diagnosing glaucoma. So what causes glaucoma? So now you see that there's the person from the side, and then there's that picture that we were just looking at, and then we're going to zoom into that rectangular box here to look at the anatomy of the front part of the eye. So on the left side of this picture here, we have a normal, healthy eyeball, normal anatomy, and then the red arrows there kind of follow the path of the fluid that's produced and drained in the front part of the eye. So you can see that it's flowing and it's draining, and that's normal, okay? And again, just to kind of remind you, this part here is the cornea, the front part, and then here's that lens and further back in the eye. So when we measure your eye pressure, we're measuring that pressure on the front here. On the right picture is how fluid wouldn't necessarily be flowing well. So you see that red arrow, it's here, but it's trapped, it can't go anywhere. And when that happens, the pressure reading that we take can be elevated, and then that can be a risk factor for glaucoma. So again, this picture just kind of shows us where fluid's produced and how it flows through the eyeball, in both a healthy eye and not a healthy eye. So that's kind of complicated and very technical as far as like anatomy goes. So I don't typically say that to patients. How I describe it to people is the front part of your eye is kind of like a sink, okay? And so the faucet, produces that water that comes out. And so there's a part of your eye that creates that fluid. And then the drain in the sink lets that fluid leave the eye. And that's a normal cycle there. But let's say you have some hair in the drain or something like that, then the water builds up, okay, because that fluid can't leave. Or you have the faucet just going full force and it's just producing a ton of fluid. So that's kind of a way to think of the front part of the eye. And so this pink balloon here is similar to the walls that are your eye. And so when the faucet is producing that fluid, that balloon starts to fill with pressure, right? And that balloon can only get so full without draining any of the fluid, okay, before it starts to do damage to the integrity of the balloon and maybe pops.
So we can go over some risk factors. As you can see from different risk factors on here, there is multiple things that would give us kind of a red flag of if you had these things that you could have. So obviously as we get older, things start going bad. So this is another thing. If you're over 60, really the African American and Hispanic is usually just a younger form. So they can get it more in their 40s, and it does cause more progression. It's just a more powerful form of glaucoma that they usually get, so it does lead more often to blindness in those two categories. Family history, That would be something, normally siblings would be your biggest risk factor for, so if one of your brothers or sisters had glaucoma, it would definitely elevate your risk factor for getting glaucoma. And then a parent would be the next risk factor. That's hard to say. The corneal thickness, Dr. Letlebo already talked about the cornea being the very front surface of the eye. So the thickness, so you can look at that thickness of how we check the pressure is going to affect if it's thin or thick. That's going to be we can over or underestimate. So just to give you an example, if you have a balloon and you indent the balloon, it doesn't take much to indent that. But if you have a basketball and you try to indent that, something thicker, it's going to make a difference. So when we're checking the pressure, it can make a difference if you have a thin or thick cornea because we could over or underestimate that. And then obviously if you've had any kind of previous trauma at all, that can make a difference on just the structural anatomy. It could cause more blockage, it could cause less drainage, that sort of thing. So, symptoms that you have. There's nothing on there because unfortunately, there are no symptoms. So you won't know that you have it. So it doesn't cause pain, it doesn't cause vision loss. There's nothing that you're going to really know that you have unless you have an eye exam and we detect that. So unfortunately, this is one of those things that is often missed, and over 2 million people do have glaucoma, and a lot of people have it that they just don't know they have it because there are no symptoms until it's well advanced. So this is kind of a symptom that you might have as the disease progresses. So when we look at the visual field is just what you see in your peripheral area. So this is how we see it on our stuff inside an eye exam. We would do one of those tests that you might have had before where you click the button every time you see something out of the corner of your eye. They can be kind of annoying. They can also be kind of boring, but they do give us really good information. So this shows somebody who would be totally normal and could see that, and then as you lose your peripheral vision, this is what we would see on a test that you would take in our office. This is looking at it more from a point of view of what you would see looking out of your eyes. So obviously normal vision, you'd have all of this that you could see. If you had early glaucoma, you can see that just the edges are being, in the periphery, are being shown that you can't see as well. The problem with this early glaucoma is if you have both eyes working, we hardly ever look just with one eye, and so your brain fills in a lot of this information. So it doesn't always show this exact picture in even early glaucoma. And obviously as it goes along to more extreme glaucoma, you're going to just get back to a tunnel vision. If nothing is treated or if it's a very advanced case, you could even eventually go blind.
And just a second note about that, once you start noticing changes to your vision, it's permanent. We can't reverse that, okay? All right, so in a normal eye exam, if you come in just for a routine eye exam to see how things are going, we would do different things here on the left, just on a normal to check for glaucoma. So we would check to see how well you could see. We would check your eye pressure. We would also do a screening visual field, meaning that we check screening your peripheral vision. If we would see some red flags in looking at these things, we would then look more deeper into what your anatomy looks like. You know, is there blockages in the drainage system? Is there areas on the front surface of the eye? Is it thick or thin? Thin is worse because we tend to underestimate what that pressure is. Thick is actually a little bit better. We would also take a really detailed look at the optic nerve, and we have different tests that we can look at it from an actual cellular, more of a nerve layer, like the layers of it, versus just looking at it as an overall picture. That we repeat some of these tests. We might see you on a first visit, have you back for follow-up testing, do some of the more detailed glaucoma work, and then still have you back for another follow-up before we begin any sort of treatment. So, common to repeat it.
Yeah, it's not usually it's something that we would just look at you and say, you have glaucoma. It would be something that we would have to do some, unless it's at a very advanced form. But if it's just we're looking for small changes that are happening, you know, year after year, time after time that we would see you. We're looking those peripheral vision tests that clicking the button. So sometimes you could have a good day taking it. Sometimes maybe you weren't having such a good day. So that can vary a lot too. So we're looking at things objectively and subjectively.
So we've kind of shown you some drawings of the optic nerve from the side, but we haven't really looked at it at how the doctors, how we see it. So these are two pictures of the optic nerves. Hopefully you can see those fairly well. So these red lines here are your blood vessels, okay? And then the tissue behind that's called the retina. And then this circle, this big kind of orange circle, is the optic nerve, okay? And that remainder of that circle that continues to be orange is healthy tissue. That's the tissue that's sending the electrical signals to the brain. Okay, so that's the functioning tissue there. Then we have it's really subtle here, but a brighter spot, maybe more yellow, a smaller yellow circle in the middle. So that's actually a hole, and that's where these blood vessels are traveling through. Okay, so that's normal and everybody has that. But with glaucoma, the healthy part of that tissue, right, the orange circle, that tissue is starting to die. And so then what happens is that hole gets bigger, and then we can see something more similar to this eye on this side. So how I describe it to people, again, functionally, the optic nerve is like a cable cord sending that electrical signal. But structurally, it's kind of like a donut, right? So a donut has a hole in the middle, and then it has the part that you can eat, right? That's the good stuff. But with glaucoma, that hole in the middle is getting bigger and bigger, and then there's less of that donut or that tissue remaining, okay? And when that tissue decreases, that means there's less signal going to the brain, and then that's when we can see changes to the visual field in your functional vision. Dr. Hunt has a different way of describing it, however.
So I look at it more of, it's a circle. So if you think of more like a manhole on the ground, and you have a bunch of hoses going in, those hoses are the nerves. So if you start pulling out those hoses, because the nerves are dying off, you're gonna have the hoses kind of go to the edge of the hole, and then you have a bigger area inside that everything kind of falls to the edge for.
Yeah. So just a couple different ways to describe it, essentially. So here's just another way to look at it, again from that cross-section that we keep revisiting. So a healthy eyeball would be on the left side further away from me, and so you see that, again, front of the eye, back of the eye, and then here's the optic nerve, and then those blood vessels are traveling through that hole there, and then this yellow tissue is that healthy optic nerve. Somebody that has glaucoma, now all of a sudden there's this bigger hole here where those blood vessels can travel through. Okay, so just another way to look at the nerve. So, we have several pictures here, and we would love some audience participation. So, so which of these nerves do you think might have glaucoma? So, how about, who thinks maybe this one? Okay. And then what about this one? Okay, so why do you think this one might have glaucoma? Yeah, bigger hole, right? A lot more yellow appearance to it. Okay, what about this one? Yeah, and similar reasonings, right? And what about this one? Right, and so you guys are doing a great job, and definitely when I look at these two nerves, I think I'm concerned. I want to do more testing. I want to figure out what's going on here. These other two nerves overall look pretty healthy, but maybe it's just the beginning of glaucoma. Glaucoma is very tricky, and it's not very well understood because there's so many different things that can affect it. So while they look fairly healthy, again, maybe it's just the beginning. Maybe that they've had a change over time. Maybe those nerves look drastically different 10, 20 years ago. So, but good job. Thank you for participating.
So if we would go through all those tests and we decide that, yes, we have a great suspicion you have glaucoma, what would we do about it? So the first line is always doing some drops. So the goal of it is to make sure that the pressure doesn't get too high. Now the pressure for one person might not cause damage, but it does in the next person. So that's always a little bit tricky to see where things are going for each individual person, which unfortunately then means that we usually see you more often because we want to make sure that things are being stable for what your condition is and for who you are. So the first line is drops. So the point of the drops is to either make the fluid not produce as much, or to open up the drainage, to open up the drainage in the eye itself to help that flow out, just like we talked about the sink. So we're either shutting off the faucet or we're unplugging the clog. So that would be the first line. The second line is if we've done drops and it still seems like from the testing that we're doing that you're getting worse, then we would usually do a surgical referral, meaning that there are ophthalmologists who just specialize in glaucoma. Like that's all they do is glaucoma. So they've done, you know, the surgical part, they've done extra schooling on just glaucoma itself. So normally we go and do a referral for that. So there's different ways, and again, most of the thing is to try to get the drainage better so that the pressure can be reduced. That's most of the surgical parts of that.
Yeah, so the other thing to note, sometimes when people get drops for glaucoma, they think it's more similar to an eye infection, and after a week they're done, their glaucoma's gone. That's not the case. Glaucoma is, typically speaking, lifelong. So when you start these drops and these medications, the likelihood is that you're going to stay on them the rest of your life, okay, to kind of prevent any further vision loss. And yes, surgery sometimes is great for some people as a second line, but some people have mobility issues and they can't get the drops on their eyes. And so then we might do surgery more on the front end of things.
So I guess in summary, yes, you have a question?
Yeah, before we have a summary, can you tell us what they do in surgery?
Yeah, so there's a couple different ways. Sometimes they take a laser and they just go, that's an in-office procedure, so it's a pretty simple procedure. You probably all put your head up in one of those little microscopes. So they would just have you do that, and then they would take a laser and do openings, so small openings, kind of like a perforation? Is that how you would describe it?
Just break up that blockage,
Mm-hmm.
open up the drain.
And if that didn't work, then they could potentially actually make a new hole to make a new drain. So that's they're able to do just recently much more microscopic drains that they can put in that are not nearly the surgical procedure they had to do before. So there's definitely improvements going on in that too. Mm-hmm.
Another comment just on new developments. So Monday, there was a new article that was posted regarding glaucoma, because like I said, it's really not well understood. And so some researchers have found some connections to actually parts in the brain that kind of influence then that fluid that's being produced. So there's more stuff being developed all the time and new developments with glaucoma.
So as we talked about, glaucoma affects the optic nerve, which is the signal that sends, it's the nerve that sends the signal back to the brain. Anyone can get glaucoma. There are some who have more risk factors, and unfortunately, from what we know right now, there's nothing that is something that you can do to try to prevent it. It kind of is more just how the structure and what your body's doing. Unfortunately, glaucoma can cause permanent vision loss, but if you're checking with comprehensive eye exams yearly, we'll definitely be able to at least monitor and be able to prevent it early. So, any questions?
What is the cost to
Great question. So you probably know more numbers than I do, so yeah.
I don't want to assume, but I assume that lots of you would be on Medicare or some sort of insurance for that. And so this is definitely something that would be part of the comprehensive eye exam, and normally Medicare would cover that, especially if you have a risk factor or if you have anything. So if it was out of pocket, most people do have some sort of vision plan. Out of pocket would be, for our office anyway, it's $135 for an exam, and that would include the comprehensive everything that we talked about here, including looking at see if you need glasses or anything like that. But most people do have some kind of coverage through an insurance, but if you were just going to pay out of pocket, that's what it would be. Mm-hmm. Anything else? Yeah.
What is the difference between glaucoma and cataract?
I'm going to go back a few slides. Oh, yeah. Just to kind of look at the, if you go. Yeah, this is a good one. So again, this is our eyeball, right, from the cross section. So glaucoma affects the optic nerve in the back of the eye, okay? Cataracts develop in the lens, which is right here near the front of the eye. And so I always tell people, you know, if you're lucky to live long enough, you're probably going to develop cataracts.
Do you need more information on cataracts, or? Okay. Any other questions? Yeah. So we are licensed to be able to treat glaucoma also. So we would usually, because most people, the vast majority of people do see an optometrist first, so we could do it. We would probably only do the referral if for some reason you needed the surgery, because we're not licensed to do the surgery, or if it was a case that really wasn't acting the way normal glaucoma acts, then we would definitely send you away to the specialist. Mm-hmm. Yeah, so we usually do the monitoring and we do all that. Mm-hmm. That is exactly right. So if you're pretty stable, we might see you just once a year, or twice a year, depending on, you know, at the beginning, you're usually going to have more testing just because of the fact we're trying to figure you out. We're trying to figure out, is there a problem, is there not? And if so, how quickly is this developing in you? If things have been stable after a couple years, then we probably don't need to see you as often. Sure. So the latest continuing education that I went to, it was a definite, it does play a part. It's a different system, but at the same time what happens is if your blood pressure is too low, you're not getting enough blood flow to the brain, which then anything in the brain isn't getting enough, especially when you lay down. So the last one I went to, they were recommending that you're considering that at least, especially if you're on high blood pressure medication that could cause it to go too low at night. So it plays a part. They're not sure exactly how much at this point, but it can play a part. Go ahead.
Yeah, love it. Yeah. Oh, yeah. Yeah, so that fluid in the tears, that's more on the superficial surface of the eye, so that fluid isn't influencing the pressure of the eye, but I mean, sometimes some of the glaucoma medications, the eye drops themselves, can cause some dry eye, just because of the preservatives that are in the drops and just how they interact with the surface of the eye. But yeah, having dry eye wouldn't necessarily cause glaucoma or go together. Correct, yeah. So the eye drops go on the eye. Yep. Correct, yeah. So an artificial tear is going to lubricate the front part, the cornea here in like the eyelids, and it's going to lubricate that. But it doesn't penetrate through the cornea to then where that drainage system is. The glaucoma medications are formulated to penetrate the cornea to then affect the fluid. Yes, correct, yep. Similar to how like a dilating eye drop that makes a pupil really big, that drop is formulated to, again, penetrate the eye so that we can make that pupil large. Mm-hmm. Yeah, it depends. Yeah, so Yep. Correct, yeah. And some of those are, once a day, some of them are twice a day. And if you're on multiples of them, then you might, kind of have it scattered throughout the day. Mm-hmm. Yeah. So sometimes, yeah, so definitely if you have like a caretaker that could do that, or somebody that's visiting you or something. And then typically when I start somebody on eye drops, I always ask them like, do you know how to put these on? Like, do you feel comfortable with that? And then I demonstrate it for them. So usually the easiest way to do it is when you tip your head back, but some people have neck mobility issues. But if you can tip your head back and then pull down on the lower eyelid, then you kind of create like this pocket for where the drop can go on to. But they do also make these things, I don't know the name of them, but essentially you put the eye drop into this plastic thing that then goes over your eye, and then it essentially ensures that it's going to get on the eye. You can find it like
Another way that I say, especially if you're not able to be as knowing where you are, or you don't really like eye drops. Most people don't really like eye drops. So what you could do is you could tip your head back and either rest the eyedropper right here and then just squeeze, and then it'll go into this little pocket, and then you can just tip your head and then it'll blink it in. And then that also helps in a way if you can't be as stable getting it into the eye itself. So, and that's the way I do my eye drops. I just tip back, just put them right here and then blink them in, because I can't always get that down and get it hit. It usually goes down my cheek. So I can do it to other people, but it's always harder for yourself.
Great questions. Yeah.
And when it comes to cataracts, some doctors say one should get an operation later, some say earlier. What are the pros and cons?
Yeah, so when the cataracts develop, the sooner you remove them, theoretically speaking, the less energy they have to put into the eye to break up the natural lens and then remove that. And, you know, again, your body's going to be a little bit younger, so maybe more likely to bounce back from the surgery a little bit faster. So that's definitely a pro to getting it done sooner, versus if it's really late and that cataract's really dense. Now, instead of being similar to like a, I don't know, like a soft jelly, now it's kind of like a really hard rock. And if you can imagine taking a jackhammer to that rock, it's going to take a lot more energy to break that up. And that energy is going into your eye. So then more likely that there's going to be inflammation, longer recovery, and things like that.
Just to add on that is, if you have it sooner and you're barely noticing anything going on, it is still a surgical procedure. And so some people want to just put off that a little bit longer so that they're not having something done where they might not notice as much effects. So there's different, we look at it more of, is it affecting your daily life? If it's affecting your daily life and now you don't want to drive at night, and now you don't want to, do some certain activity that you're wanting to do, then it's definitely time to have something done. But if you don't even notice it and we're just seeing signs of it in your eye, I probably wouldn't worry about it then, because it's not really affecting your day-to-day activities.
Yeah. Yep. Yeah, definitely. Okay, so injury to the eye. So let's say you got like a blowout fracture. You were into boxing when you were younger or something like that, or soccer, and a ball hit you there. So the part of the eye that produces the fluid is right here. And so again, let's say you got a soccer ball to the eye, it can damage these muscles here that are producing the fluid, and it can change the structure of what it looks like. And so then when that's damaged, when it goes to drain it, it just doesn't do it quite as efficiently. No, not really. Sometimes they might take a laser to, again, open the drain. Yeah, but not typically. And typically when people do have that damage, it doesn't show up right away. It's usually pretty, like maybe 10, 20 years later that now you're noticing problems from that damaged part. Because the eyeball, right, is like a sphere in a globe 360 this way. This is just a little cross section of it. So you have that tissue and those muscles all the way around your eye. So even though there might be damage to just one part, it probably won't affect you for a long time because it is only one section of that tissue. Right, yeah. Cataracts are way more common. Yeah, that sounds right. Yeah, like 1 to 2%. And like you were saying, about 2 to 3 million people in the U.S. And glaucoma is in the U.S. the leading cause of blindness for people over 60. Because again, it's not painful, and it doesn't really affect your vision until it gets pretty far along. But yeah, cataract's very common because, like I said, we're all being exposed to UV, light and radiation over the course of our life, so we're all going to get it eventually.
Is there another benefit to having cataract surgery if you wear glasses, that there's vision correctness that's included as part of the surgery?
Yeah, definitely. So cataract surgery, like you're saying, they remove the lens that has this fogginess or something like that, and then they put a clear one in there, and yes, they can put your glasses prescription essentially into that lens so that you don't necessarily need glasses for far away. And another benefit of doing that, when we look at this picture here, so this lens, right, is this oval and it's taking up some of that space in that drainage area. An implant after cataract surgery is very thin, so all of a sudden that drains a lot bigger. That's another benefit.
I usually say if you have to have something wrong with your eyes, have cataracts, because you can have a lot more benefit, especially if you wear glasses with a cataract surgery. So it's not, yes, it's something to go through, but there's a cure, you're done. It's not like some of the other eye diseases where you're just constantly monitoring and hoping it doesn't get worse. So, anything else? Yeah. Well, I think it depends on the person. So sometimes people can have a stent and have it for a long time. Sometimes it depends on, do you have a micro stent? Like you don't have a big bubble underneath your eyelid. Okay, so you probably have a micro one. Yeah, and those are relatively new, so I'm not sure if they know exactly how long, but the thought is if they don't get scar tissue or they don't have any issues, that it'll last a long time. So, yeah, and that can be the benefit of having a surgery, although if you get to the surgery point, it's not always where you want to be either, There's pros and cons of it. But yeah, it's nice not to have to take the drops. If it's not being controlled completely with the stint, then they might have you on, but it's usually a lot less drops. So if you were taking a combo drop and maybe 4 of them or whatever before this, yeah, if you had 4 days, then you might go back to just 1 a day. So it still can be a much better life situation than before.
Fantastic questions. Any other questions? Okay, well, thank you so much for your time and your attention. We really appreciate it and loved all the questions. Thank you so much.